Yes, come for the photo. Very important. Excellent, doctor. Excellent. So, let us continue with the second case. So this patient was presenting with severe chest pain, and he had no other previous examination. And these are the type of images. So he went for cardiac ECG-gated examination. And these are the images of the coronaries after reconstruction, curved MPR. So we have some software that allow us to nicely see the whole length of the coronary, as you can see. And again, in this patient, you can see that the coronaries are okay. And this is a 3D image. I will show you another 3D image now on the workstation itself, but the coronaries were okay. I think everybody will get the diagnosis easily. Yes. Excellent. Who said aortic dissection? Okay, there is a cardiology group here, I think, or there is. Okay, so there is aortic dissection, but I would really like to give the gift if you get the full diagnosis. So I will show you the set of images after injection of contrast. We'll go from down upwards. Maybe we can do it faster. You can see the aorta here. Okay, I want a more specific answer. Yes. Or Stanford. Okay. So here is the problem. You see here the dissection. And if we stop the images, what is really important and what is really crucial is to look at the origin of the coronary arteries. So you can see here that the left main is arising from the true lumen. There is no problem, and it is bifurcating into LED and LCX. Everything is okay. And when we look at the right coronary artery, here it is. It is arising from the true or the false lumen? Doctor, what do you think? Arising from the true or the false lumen? And this is the very important. Yes, and this is the problem. Okay, excellent. I think doctor should get a gift. Father, doctor. Excellent, doctor. So this is a Stanford A dissection with involvement of the right coronary artery, and this is a problem for this case. Let's go for a third case. So this male patient also performed a cardiac ECG-gated exam, and he had an irregular heart rate. This case is rather difficult. A chest X-ray, and patient is a smoker. This is very important. And his chest X-ray showed prominent right cardiac chambers. This is one image. You can see that the heart is big, especially the right-sided, the right chambers. The right atrium is huge. The right ventricle is also huge. I will show you on the workstation the images. So these are the images from down to up. Aorta is okay. Here is the heart coming, a huge heart. And as you can see, the right ventricle is huge. And actually, they were suspecting in this case pulmonary embolism. And there was no pulmonary embolism. Why they suspected pulmonary embolism? Because they were looking for pulmonary hypertension, as the right side of the heart was big. And no. Sorry? Yes, cardiomyopathy is a very good answer. What type of cardiomyopathy can affect the right side of the heart? Who said ARVD? Excellent. Excellent. It was really a suspected case of ARVD. He was suspected to have pulmonary embolism. We went and we looked for the pulmonary artery. It was okay. The right side of the heart was huge, non-contracting at all. Ejection fraction on the right side was very low. But this wasn't the only problem.
What is the symptom of the patient?
He had some arrhythmia. Okay, he was coming with arrhythmia. But more and more worrisome in this case. No, I will show you. He was a chronic smoker and he was really unlucky. And we found a very suspicious pulmonary nodule, accidental finding. No, yes, I agree. We asked for a cardiac MRI. Yes, I totally agree. We suspected. We said we should go for. You see this nodule? Yeah. Very suspicious. And for this case, yes, in fact, it was a case of query ARVD. I couldn't say that it is a sure case of ARVD. We asked for a cardiac MRI. But the very important and crucial point is to follow up this nodule that we found in the lung, which was irregular, highly suspicious. It could be a small bronchogenic carcinoma. Excellent, doctor. You should come for us. Okay, in the next two cases, I will help much more because they are very difficult. We'll make it in the form of a discussion. So, as we said in the lecture, we can also use multi-detector CT for diagnosis of congenital heart anomalies, okay? And we can use low-dose protocol with low radiation that are very safe for our children. And this is a small female child which was presenting with cyanosis. She was less than 1 year old. And I will explain a little the anatomy. And you will notice that the quality of images is much lower than the images that we saw lastly in the CT. And this is normal because the heart rate is very rapid in these children. And we are acquiring an examination very rapidly, so the images are of less quality. Yet, we can get a lot of information. You can see here the right ventricle characterized by the moderator band and the right atrium, and left ventricle, okay? And everything is okay till now. We can confirm that the heart is towards the left side. This is a case of levocardia. There is no position, a normal levo position and levocardia. The liver and the spleen were normally situated. There was no situs inversus. Okay. Still, we confirmed also that there was normal AV concordance, atrioventricular concordance. We mean that the right atrium is opening in the right ventricle. Everything is okay. Same for the left side. The left atrium is opening within the left ventricle. Everything is okay. Moderator band confirming the right ventricle. So this is the usual way we like to think in a case of congenital imaging. Then we confirm ventricular-arterial concordance, a very hard word. Actually, it's very simple. Just confirming that the aorta is coming from the left ventricle and that the pulmonary artery is coming out from the right ventricle. And it was okay for this child. So where's the problem? These are the pulmonary veins, okay? And normally the pulmonary veins are going where? Yes. Who said? Okay, doctor. Excellent. Let me show the case. So I will show the case. Yes. Shut down. I must show you the case. Yes. So when we focus more and more on the case, you can see that the pulmonary veins, normally they should enter the left atrium. You will tell me, where is the left atrium? Here is the left atrium. And here the 4 pulmonary veins are entering beside and behind the left atrium. Here's the left atrium, and all these veins are entering behind. So this is not normal, and we call it total anomalous pulmonary venous drainage. I will show you a small diagram to explain you that. So this is the normal. This is the abnormal situation. Normally, the 4 pulmonary veins are entering within the left atrium, okay? But in this case, they all connected together via a big vein that entered the coronary sinus in this case, and we call it total anomalous pulmonary venous drainage. It's a complex case, but it's just to show you how, with an ECG-gated examination, we can detect very, very small anomalies. Excellent, doctor. Come with us. Thank you. And the last case, and it's not CT, just to change a little. So actually, we're thinking of getting a cardiac MRI machine in our new center, hopefully. So I will show you a cardiac MRI and what we can do with an MRI, a full comprehensive cardiac MRI exam. So this was a preoperative investigation for a male patient. He was going for a surgery, normal surgery. He had no complaint. Then he went for an echo. And on echo, they found an intracardiac, a right atrial intracardiac mass, okay? So they went for a transesophageal echo, which confirmed that it was a right atrial mass, but they needed more information. They needed to characterize this lesion, what type of lesion, what it is. So I will show you some slides. This is a protocol we are using just to give you some orientation, because cardiac MRI is rather hard. So we like to take some what we call black blood images. These are normal anatomical images in which the blood is totally black, as you can see. And we take them in axial and coronal and sagittal, routine, just to have an idea about anatomy. Then we acquire some white blood images in which the blood is totally white, as you can see. And we can even take some images showing the contraction of the heart in a short axis view. As here you can see the left ventricle contracting. This is a normally contracting left ventricle. Then we can go for some special technique with fat suppression. So we suppress the whole amount of fat that is present. This is a very important key image that can allow us to detect the edema within the myocardium. Then we inject contrast and wait 10 minutes, and we acquire what we call delayed myocardial enhancement or late gadolinium enhancement images. This is a short overview to give you an idea how we go for a cardiac MRI exam. So let's go for the case itself. So the patient, we performed some black blood images, as you can see, in coronal and sagittal, and you can see here there is something abnormal. The question is, it is inside or outside? No, it is not a thrombus. No. No, it is not a myxoma. Take your time. Everyone wants the gift. Okay, so it is something white. Take care. Something white, and it is below the heart or inside of the heart. We don't know. Okay? We'll go for the next set of images. We injected contrast, and you can see that this lesion didn't take the contrast. Didn't take the contrast, okay? Pericardial, no. Then take care, because everybody will get it now. This is the key image. The key image is fat suppression. So this is the images the cine white blood images, you can see the lesion is outside of the heart. You see how it is? And then, no. Then we perform fat suppression. And this is the lesion after fat suppression. A lipoma. Yes, excellent. Okay, two gifts, no problem. So it was an extracardiac lipoma. Mohammed, can we afford 2 gifts or not? Yes? No problem. Okay. So both doctors. One here. Doctor, please.
How can know this lipoma?
No, it's a lesion outside of the heart. Okay. Let us give the gift and I will discuss with you. Okay. Doctor? Excellent. So I will just finish this case rapidly. So it was the differential diagnosis, like you are saying, I totally agree. It's a mass-containing lesion. It's a fat-containing lesion, okay? So it could be a lipomatous hypertrophy of interatrial septum. No, because it wasn't inside of the heart, it was outside. It could be pericaval fat invaginating into the IVC. No, it wasn't within the IVC. It could be a pericardial teratoma. No, pericardial teratoma is very aggressive. This wasn't aggressive, it was well-defined. It could be a hernia. No, it wasn't a hernia. We thought it was a hernia, actually, at the start. It could be fatty metaplasia after remote myocardial infarction. No, it was outside of the heart. So we were thinking a lot. I totally agree with you. We should go for differential diagnosis. But we went into literature and we looked a lot, and we found that we could find some lipomas in 25% that could be extracardiac, and this was our provisional diagnosis. So for this case, it was an extracardiac lipoma for differential diagnosis. I agree. Thank you very much. Thank you very much, everybody.
Ahmed, for the quiz and for the way you went through the structuring of finding out how to reach a diagnosis using cardiac CT and cardiac MRI. And Dr. Ahmed, this might come